Hello, my name is Jeff Hauk, and this presentation was made at the Combined Sections meeting of the American Physical Therapy Association in 2019. The title of this talk is Does Multidimensional Health Assessment Using Promis Scales Enhance Clinical Decision-Making for Patients with Orthopedic Problems? And it's an observational case series design. I'd like to acknowledge my co-authors at George Fox University and point people to a publication of preliminary data from this presentation in the Orthopedic Physical Practice Journal, fall of 2018. What is Promis? Promis stands for Patient Reported Outcome Measurement Information System. The Promis tools were sponsored by the National Institute of Health and developed by experts across the United States. To find out more about the tools and validation studies, go to healthmeasures.net. Here's the website. So what makes Promis scales unique? They're generic or agnostic to disease, and this means they can be used effectively to measure patient outcomes across diagnosis. So they're just as effective in recording the attribute they're trying to detect in people with cardiac disease as musculoskeletal problems. They were developed using item response theory, which is an upgrade over classical measurement approaches. And then finally, they are computer adaptive, meaning they have fewer floor and ceiling effects than measures we're used to, and that they can be administered quickly, as an example, approximately 1 minute per attribute. So how might Promis scales help us clinically? In a typical patient with low back pain, we might use the Oswestry Disability Questionnaire and numeric rating scale. These scales capture pain, interference, and physical activities, but we know that patients' symptoms extend to psychological and social problems as well. The CAT-based Promis scales allow us to extend our clinical assessment to these other domains. This study focused on using self-efficacy and fatigue in addition to physical function and pain interference that are captured using typical disease-specific measures. The research question was how useful are these additional scales, i.e. self-efficacy and fatigue, in routine clinical practice. So the purpose of this study was to examine the usefulness of 4 generic Promis health symptom scales in patients attending a small rural orthopedic physical therapy clinic at their initial evaluation. The 4 scales are listed here: pain interference, physical function, fatigue, and self-efficacy of symptom management, all CAT-based scales, and usefulness was defined as the proportion of symptoms, correlation among the scales, and then some clinical case examples. The sample was 125 consecutive patients in a rural outpatient orthopedic clinic. The patient complaints included spine, lower extremity, upper extremity, and multiple regions. This is typical of an outpatient physical therapy practice. The Promis scales were administered using computer adaptive tools on the iPad that's available for approximately $500 a month from healthmeasures.net. What proportion of patients report a primary health symptom of physical function and pain interference, and then these new symptoms, self-efficacy and fatigue, that we're able to capture with the Promis scales? The hypothesis was that equal reporting of these health symptoms would occur at the initial evaluation. So in order to classify symptoms identified by the Promis scales, we first needed to establish severity. One look at severity used the worst symptoms that were above 50, and that's a pretty simple examination, just taking the highest score. A second approach was to rank the symptoms as within normal limits, mild, and severe. So in this histogram, the Promis physical function scale, we see on the x-axis the Promis T-score, the standardized score relative to the U.S. population, where 50 would represent the U.S. average, and 10 points, i.e. like 60 here, would be 1 standard deviation. And we can see that for this clinic population, they're approximately 1/2 standard deviation below normal. To classify patients as within normal limits, mild, and severe, we used half standard deviation increments. Here we've categorized patients by 1/2 standard deviation above normal, and here we've categorized patients half standard deviation below normal in red. The yellow indicates patients that are worse than normal by 1/2 standard deviation. Here's the proportion of patients classified by half standard deviation increments. The y-axis is the proportion for each scale. The x-axis, we have each scale identified: pain interference, physical function, fatigue, and self-efficacy. The blue line is 50 or normal on each scale. The first red line is a half standard deviation worse than normal, and then the second red line is 1 standard deviation worse than normal. The smallest proportion of patients were above normal. The highest proportion of patients with a half standard deviation or worse was pain interference, with over 60% of the patients reporting with that level of disease severity. The least proportion of patients having a half standard deviation or worse symptoms was fatigue at 40%. Although this gives us a look at each individual scale, it doesn't reveal how the symptoms occur together. To do this, we first classified patients as within normal limits when they were half standard deviation worse or better than normal, half to 1 standard deviation worse as mild to moderate, and 1 standard deviation worse as severe. So here we use a color-coded approach to illustrate the proportion of symptoms occurring together in this subject sample. This light blue indicates that all symptoms are within normal limits. The dark green indicates that physical function and pain interference are mild or severe, and that fatigue and self-efficacy are within normal limits. The bright blue indicates that fatigue symptoms are higher or worse than self-efficacy, and the yellow indicate that self-efficacy is more severe or higher than fatigue, and the red means that self-efficacy and fatigue had equal severity. This pie chart shows patients classified by their worst symptoms. Note that 68% of the patients fit like our typical view that the primary complaints with musculoskeletal problems are physical function and pain interference. However, if we use the classification system where we look at how symptoms combine, we have a different view. So in this case, 20.8% of patients are within normal limits, and we can see that in the blue. Only 20% have pain and physical function problems that exclude self-efficacy and fatigue, and 59.2% have either high self-efficacy, high fatigue, or both that combine with pain interference and physical function. So our first hypothesis was accepted that fatigue and self-efficacy would be relatively common problems in musculoskeletal patients. The second objective was to look at the correlation among the scales. Here we define a weak correlation as insufficient convergence to exclude that scale. So in essence, that scale is still valuable as a separate measurement in patients' care. A strong correlation would indicate that there's sufficient convergence that the scales really could be considered together. So for example, if physical function is high, then pain interference would be low, and vice versa. So those two scales are intercorrelated sufficiently that they're really capturing a similar construct. And very strong correlation above 0.8 would indicate that the scales are essentially redundant, and having both scales to be used clinically is really unnecessary. So here are the correlations among the scales. We have pain interference, physical function, fatigue, and self-efficacy, and then physical function, fatigue, and self-efficacy here in the columns. So what we can see is that all of the scales are significantly correlated. However, the correlations are weak except for physical function and pain interference. And we can see the 0.73 negative correlation here, indicating that as pain is higher, physical function is less, and vice versa. So this suggests that pain interference and physical function should be considered together. So the third hypothesis has to do with how the case descriptions will help us with clinical decision making. We know that there's evidence-based treatments that address physical function and pain interference, fatigue, and self-efficacy. The Promis symptom scales can help us make clinical decisions on which treatments to choose, targeting the particular symptoms that are the most severe. So here are 5 cases for shoulder, number 1 and 2, foot care, number 3, and spine patients. The cases are ordered 1 to 5 based on pain severity. So green indicates within normal limits. Red indicates mild or severe symptoms. For case 1, see the green scores here, all symptom categories are within normal limits, indicating the need for minimal treatment or reassurance. For case 3, this is the foot case, pain interference and self-efficacy indicate severe to mild symptoms, and physical function and fatigue are within normal limits. So the treatment choices would target then pain interference and self-efficacy approaches. For case 5, we can see that essentially fatigue is the most severe symptom, followed by pain interference and physical function. But self-efficacy is fine. So for this patient's care, treatment should focus on physical function, pain interference, and fatigue. For cases 2 and 4, we can see that essentially all symptoms are in the mild or severe range. These cases illustrate that patients with relatively low pain, here we see a 62 for case 2, or high pain, 70 for case 4, symptoms may occur across all these different categories, suggesting involvement at many different levels for patients. And in this case, a more comprehensive approach might be necessary. So in conclusion, as we defined usefulness, the integration of these scales into patient care was supported. There were relatively equal proportions or just high proportions of patients that had fatigue and self-efficacy of symptom management symptoms that were occurring in parallel to physical function and pain interference problems. And the correlation amongst the scales wasn't sufficiently strong to suggest that treating the other domains would have an effect on fatigue and self-efficacy, and supports their independent assessment in clinical care. And then finally, there were case examples that directly correlated to clinical decision making in clinical practice. Now, some caution is prudent. In essence, this data doesn't prove that it improves outcomes. It just suggests that a more comprehensive approach is possible and would address symptoms that patients are experiencing. And it also doesn't validate which set of Promis scales are the best to capture, because it's likely that other psychosocial domain scales or even physical scales might show a sensitivity to patient complaints as well. So future data or analysis might consider social scales or other mental health scales. So thank you for listening. Here's a shameless plug for some recent articles that are coming out that demonstrate how Promis scales could be used clinically. So essentially, one current leader in physical therapy defined courage as the willingness to take risk once you know the odds. Optimistic overconfidence means you are taking the risk because you don't know the odds. We think the Promis scales put us in the position of having courage rather than optimistic overconfidence when treating new health domains like fatigue and self-efficacy and patient care.